Daddy.
Good afternoon, everyone. It is 4:30, so we'll go ahead and get started in just about a minute. But in the meantime, we welcome our representatives to drop your name into the chat so we can document your attendance here. So thank you all for adding that in, and we'll get started shortly. Wonderful. Thank you all for adding your names in the chat. And for those representatives that are joining us by phone, if you want to come off mute now and introduce yourself, we'll make sure to document that as well. Thank you so much. Wonderful. All right, we're going to go ahead and get started. We have hit quorum, so we're going to begin, and we welcome those that are joining us shortly. And we want to thank you all for coming back after only 2 weeks. I know the space between these latest meetings is relatively short, so I want to thank you again for taking your time on a sunny Thursday afternoon to join us. Really looking forward to our time together today. Our 2 big topics of the day, after a couple follow-ups, will be a review of some baseline data on our focus population that is hot off the press from our analytics team. Really looking forward to Mallory from our team walking through some of the key learnings there and getting your feedback on a public dashboard that they'll be building. The second piece I'm really excited to cover is on respite care. It's going to be the first of multiple conversations on this, what this benefit could look like in a Medicaid reimbursable structure. It's a really crucial component of our home and community-based services. So I'm looking forward to hearing from you all on the right way to design this for the state of Nevada. So with that, as a reminder, representatives, please add your name in the chat as you join so we can mark you down as attendance. And we're going to go ahead and get started. So I know since the last time we met, there have been many significant changes, both at the federal and the state level. You may notice a new brand for us here at the Nevada Health Authority. We're really thrilled that launched on July 1st of this year. We recognize that there are a lot of changes happening in the Medicaid world. And so I want to encourage everyone to join us at a summer stakeholder workshop, which will be held on Monday, July 28th. So in just about 3 weeks at 2:00 p.m. It's a virtual event. And we're going to be covering, I think, a lot of the key topics. We'll talk about the health authority restructure and what the vision is for this new model in our state. We'll talk about impacts of federal legislation that passed on our Nevada Medicaid program and share more details there. We know our legislative session, we gave a short review of that at our last working group meeting, but we have a lot more exciting details about what implementation will look like, including timeline for some of the new services and rate changes on our end. And then we'll also give some project updates, and you'll see some familiar children's behavioral health content there as well as we talk through some updates for the broader public there. So for those that are interested in joining, please keep an eye out on our public notices page. The agenda and Teams access links are there. These slides, once they're posted on our website by tomorrow morning, you can click that link as well and you can join. But we really welcome you to attend. We know you all probably have many questions about what these impacts will look like, and we're really excited to talk through all of those at that meeting. So with that, we have a fun update and request for you all. which is that we need your creative thinking and recommendations on a name for our specialty managed care plan. While we've been using the acronym CBHT for this work, we know that doesn't quite stick, and we want to move away from our Medicaid speak and all of our acronyms. And so we want to learn from other states that have taken approaches like Ohio RISE or Washington's Apple Health or New Mexico's Turquoise Care to really name this program in a way that resonates with our community and our stakeholders. So we are asking for your input to help us name this plan. I'll have someone on our team drop a link in the chat here, but we have a public form where we welcome folks to drop in your name. It's anonymous. Whatever creative ideas you have on what our Nevada plan can look like, we'd love to hear them. Please submit those within the next 2 weeks, so by Friday, July 25th. Our working group representatives will have a chance to vote on the top names based on those submitted, and we will make that final selection and announce it at our August working group. So put your creative thinking caps on. We welcome your ideas and look forward to hearing those in the weeks ahead. And my last Newsy Notes update here before we turn it over to the team to go through some content will be on an upcoming summit that our team and Jessica Gogochia, our co-chair, will be leading a youth and family representative deep dive on care coordination. So we recognize these working group meetings, while they're really great content and we really appreciate your input through them, we always know there's never enough time. And so we're looking to find other forums and other ways to do a deeper dive, a one-off deeper dive on some of our really key topics. And so the first of those is going to be a focus on what should our care coordination model and the specialty plan look and feel like to our youth and family members in Nevada. So the goal is really to elevate those with lived experience navigating our systems here to give their input on what this should look like come January 1st, 2027. Help us think through some kind of design principles and other key areas that we're working on internally as we prepare for the procurement for this plan. And so we look forward to that conversation happening late August, early September virtually. We recognize that many folks on this call are not part of our youth and family representatives, but have great input on this as well. So we will be having some discussions in our working group meetings as well on this, and we'll have other opportunities for folks to provide input, but we're really looking forward to the small group conversation with our youth and family members to get things started there. So with that, more to come soon over email on that piece, but just wanted to introduce it to the group here. And with that, I'm going to turn it over to my colleague, Mallory Mokri, who's going to walk through our baseline data overview.
Hello, everyone, and thanks so much, Anne. As Anne said, my name is Mallory Mokri, and I work with the innovation team here at Nevada Medicaid and have the pleasure of working with Anne. And so today I'm going to be walking through highlights from our baseline data report. This report is a milestone in our transformation project, and we'll get started with the first slide here and start with a key term. What do we mean by baseline data? Baseline data refers to a starting point. It's a snapshot in time that helps us understand how youth are currently being served across different systems. And the snapshot, it's something that's required under our DOJ settlement agreement, and it helps the DOJ and the independent reviewer, as well as the state, evaluate whether our system is meeting expectations and where we need to improve. We focused on a group that we're calling the focus population, and these are Medicaid-enrolled youth up to the age of 21 with complex behavioral health needs. Many are involved in multiple systems or have experienced institutional care. And the data that we're going to show you on the next few slides reflect data collected through the first quarter of 2025. So that's January through March, using sources that haven't been integrated quite like this before. That's Medicaid claims and enrollment data, mobile crisis response records, and county-level child welfare and juvenile justice involvement. So this gives us our first integrated system view and will help inform our approach and also our accountability framework as we move forward. So on this next slide, let's take a look at who is currently in the focus population. This slide kind of gives a sense of the youth that we're actually talking about. So between January and March 2021, currently in our baseline data, we've identified 1,119 youth in the focus population. Now, just to note, this is data collected primarily at this point through claims data, which always has a lag, about a 6-month lag at least. So we plan to refresh the data in about 6 months' time. But currently, that's the figure we have. And some notes on this, as you'll see on the left, on the focus population, February includes, so when we look at this and the numbers go up, February includes new youth added in February, plus those who are eligible as being part of the focus population in January. And then March includes newly eligible youth in March, plus those eligible from January and February. So you can see that. And let me just explain briefly what qualifies a youth for this group. This includes youth who used intensive behavioral health services, such as hospitalization, residential treatment, or mobile crisis, and who often have co-occurring diagnoses or involved in other systems like foster care or juvenile justice. And here's some key takeaways from the data. What we see is that 68% are teenagers. They're adolescents between the ages of 13 to 17. 40% have a diagnosed substance use disorder, which is about 15 times that of the general Medicaid population. 35% have an intellectual or developmental disability, and nearly 1 in 5 are involved in foster care. We've also included some comparisons here to the general Medicaid youth population. So the focus population that we've identified, they're more likely to be white, with 37% versus 26% in the general Medicaid youth population. And also in the focus population, we're more likely to live in rural areas. That's 13% in the focus population versus only 7% in the general Medicaid youth population. So this data suggests that the youth in our focus population, what we're looking at here, are not only more complex clinically, but they also may be more likely to face geographic and structural barriers. So looking at the next slide, this slide here, what services are the focus population, the youth that we're looking at, what are they using? Let's take a look at how they're interacting with the system here. This slide shows both crisis and institutional care and also community-based services. Starting with crisis and institutional care, you'll see these bars on the left here. 67% had at least one mobile crisis encounter and 28% had multiple. 64% were hospitalized for behavioral health reasons. 51% of the youth visited the emergency department, and many with repeat visits. And 34% stayed in psychiatric residential facilities. And the average length of stay here is 114 days, and many of these youth had stays longer than 6 months. On the right side, we've listed here, we see some community-based services, or HCBS, home and community-based services. And within the first quarter of 2025, so between January and March, 62% of youth in the focus population received at least one home and community-based service during this period. The top services were individual therapy at 38%, behavioral supports at 34%, and case management at 26%. So even though many youth are accessing services in the community, we see that institutional care is still playing a significant role, which tells us, we have more work to do to shift the system toward prevention and more home and community-based care. So what does this tell us? How can we summarize what we're learning so far at this snapshot data and where we need to go? A key takeaway here is that our system is still reacting to crisis rather than intervening early. Youth with the most complex needs are heavily reliant on emergency departments, hospitals, and residential treatment facilities. And at the same time, this population often falls through the cracks between systems, meaning data from child welfare, Medicaid, and behavioral health still live in silos, and that can make coordination difficult. From this data, we see a clear need for early intervention to reduce crisis escalation, coordination across agencies so that services aren't fragmented, and shared data systems to track needs, services, and outcomes over time. And that's exactly, what we're here together for what this transformation is aiming to fix. So that's just a brief, baseline snapshot overview. Obviously, this will be ongoing reporting over time, but really we wanted to share this as soon as we had it and open it up to a brief discussion and hear from our working group members what your initial thoughts are. Take a moment to reflect, and we have some prompts here to help us think through how this data can help inform the rest of our work. So thinking about what we've just gone over, what data surprised you? And also, in addition to that, what types of data would be most helpful to include in a public dashboard so that families and communities can see how we're doing? Any thoughts was it surprising? I see from Natalie.
Useful to to see either monthly, because I think anything other than monthly is probably too frequent, and updates of this is how many days from somebody was identified to actually connected to services. Because like I know insurance is supposed to be able to connect you to non-urgent services within 10 days, but I also know that that's rarely the case. But I think that's something that would be a very useful, helpful metric to see and would have more meaning and more value. As long as it wasn't one of those ones where it says 80% of cases get placed with somebody within 72 hours. And it's like, yeah, all the ones that are easy, not any of the ones that people actually need the extra support for. We've all seen those advertisements that are lying with numbers.
I appreciate that, Matthew. And I agree. I think one of the pieces that we'll start looking at, to Mallory's point, this is our first snapshot, but the more reporting that we will have, we can trend over time. And that's a great one that we can look at is what is the time between, for example, screening and initiation of services and clinical assessment and initiation of services, and how does that trend over time is going to be a really excellent one for us to add to the list. So thank you for that. I'm also seeing, Natalie, your comment in the chat here. Appreciate that. The question is, what's kind of the black box of data, which is where were people needing care and not able to access it? And that really speaks to our need to look beyond just claims data, and what we're really working with our sister agency partners to do is find other data sources that can show when clinical service wasn't delivered and it's not showing up in claims, how can we reflect that? So I appreciate that. And Dr. Courtney, to your point, prior authorization denials is something that we are able to look at. So that's something we can add to the list as well. So thank you. Sherilyn, I'm seeing your hand raised.
Yeah, thank you. Sherilyn Marwood for the record. I was curious about the mobile crisis response teams. Are those in-person visits? Is that virtual on telehealth? How are you counting that? And knowing that a lot of our rural regions do not have any mobile crisis response, where did that data come from? Potentially maybe the urban areas and not so much our rural regions. So I just want to make sure that when we're talking about that data, we're defining that we don't have a lot of those teams out in the rural regions. So that's probably showing more of our urban. So if we could just clarify that, I would appreciate it. Thank you.
Yeah, and I think with our mobile crisis response data, that's something that's we're building out. So as a part of building out and having our baseline data system, we're identifying what data we currently have available and what we don't. And that's a part of this baseline, and that's something that's going to be part of our refresh. So as part of this, we have collected, response team data records that were available at this point in time. And that's something to note, what was available and what wasn't available.
Absolutely. No, thank you, Mallory. And I think to your point, Sherilyn, as well, this does reflect data from our DCFS-led team, as well as our Washington County-led team, but there's ways we can maybe clarify where those multiple data sources are coming in. And as well, we can regionalize it by county. All of this data we have broken down by county as well. Mallory's been working really closely with our team on that. So we can think through the right way to display that, recognizing there's still some pretty small numbers at our county level totals right now. We want to be respectful of patient privacy and trying to show this in aggregate as much as possible. So as we have more and more data, I think that'll be easier. And I appreciate you pointing out we really need to reflect the unique challenges of crisis response in our rural areas. So thank you for that.
Thank you. And just on a second note on that, I know those numbers are small, having worked out in the rural, so you might break it out in behavioral health regions or something such as that. But I think it really is important on that way. So I'm glad you guys are thinking about that moving forward. Appreciate that. Thank you.
Yeah, absolutely. And I think that raises a good point overall. I think Mallory did a great job explaining. We're seeing this trend over time, month over month, because kids could only hit our focus population for the first time in the state in January, right? Because of the way the settlement agreement defines the focus population. So this isn't necessarily a look back, it's a look forward. So we do expect these numbers to increase pretty significantly as the year goes on. And we'll continue to keep this group posted as we see those numbers change.
And it's helpful also to hear these questions. I'm sorry, just in terms of also building out our public dashboard. And so please keep this feedback coming. It can help inform as we do build this out in the months ahead. Sorry, Matt, I interrupted you.
Oh, no worries. One of the other things that I was going to bring up that I'm kind of goes into that, I guess, more black box data, because it's more services that are never connected or realized that should have been connected, is, so I work with a lot of foster kids who are religious adoptions, so they're completely outside of the state support system. But then adoptees, whatever you refer to the parents in that situation, sorry, usually it's a grandparent, but it can be something else, or someone else, I should say. Where they then get super overloaded and they don't have access to the supports that when the foster care kids are registered with the state, because they just don't have access to it. And then they end up first connecting, like you were talking about in the earlier slide, where now it's okay where they're at Desert Springs or some other much more higher intensive level of care, because the family can't access respite services and can't access some of the other things where doors are made a little bit more open, or there's a little bit more handholding to guide you to getting access to those supports for those kids who are essentially foster kids. It's just they're not through the state system, they're through a church or other parallel system that we don't have ready access to that data. And I don't know that we can necessarily get ready access to that data either. Like, I don't know if they give it to us, but that's another place where we're seeing stuff. And I've tried to get those kids services through my own connections as a foster parent. Right, of, hey, here's this kid, would meet all of these things, just went through a different system. Oh, we can't do anything because they didn't go through the state, so there's nothing that we can offer them. And so ways for them to be able to access those kinds of things would be, I think, incredibly helpful.
No, thank you, Matt. I think you're touching on two really important things. One being the data piece. How can we try to collect data for kids that are not necessarily involved in the system or are involved in more tangential ways in the system currently, and we want to get better connected. And I think the second piece you're raising is, what does that front door look like when it's not necessarily traditional foster care placement? So that's something I'd love to think through as we continue to develop the screening and assessment system, because if that child is Medicaid eligible, they could access those services like respite, as you mentioned, through the specialty plan as part of that at-risk population. I think the challenge, of course, always is we're limited by the eligibility thresholds of the Medicaid program itself, but I think there's some nuances there that I'd love to talk through with you. So thank you for flagging that, and that's a good one for us to take back as well. All right. I know we're getting close on time, and I do want to make sure we have sufficient time for our respite care discussion. So Melanie, any final words before we close this piece of our working group today?
No, thank you all for your time. And just, keep this in mind that this will be a part of our transformation efforts. And so as you're thinking about this, and as we gear towards building out a public dashboard, think about that data, and we'll continue to bring this for your feedback. So thank you. Thanks for making the time today.
Wonderful. Thank you, Melanie. I really appreciate you walking us through that. With that, we're going to turn to our respite care discussion. Really looking forward to this one. And another familiar face, Matt Burdick, will be walking us through this benefit design conversation. So Matt, I'll turn it over to you.
Thanks so much, Anne, and great to be with you all. I was with this group a few months ago, but as a reminder, my name is Matt Burdick, and I, like Melanie and Anne, I'm working on the innovations team here at Nevada Medicaid, really focused on benefits design and other work around our children's behavioral health transformation. Want to spend some time today talking about a new benefit that we're looking to stand up in the world of Medicaid, respite care, specifically for children and youth with behavioral health issues. And I know this has been a topic that has come up quite a bit, and so really excited to give this group's feedback. We're going to spend today just doing a little bit of a 101 on respite care. And full disclosure, I am as new to this, and we are as new to this topic as anyone in this call, and there probably are people in this call that understand respite care much more deeply than we do. And so we're really looking forward to the wisdom and expertise that this group brings, as we are literally on the ground floor of designing this. And so we've got some constraints that the settlement lays out for us that I'll talk about, which are mostly just things we have to work within, but really we've got a lot of flexibility in terms of how we design this. And so this will be the first of several discussions on this front. But to kind of kick us off, what is respite care? And as the little image on the slide here indicates, respite care is a chance for families to recharge their batteries. As we all know, caregiving for youth and kids with behavioral health challenges is a lot. It's a lot for the youth, it's a lot for their families, and oftentimes a break can really be the difference between a crisis situation escalating and it resolving. And so respite care is really intended to provide parents and other caregivers that temporary break and some additional support so that they're not alone in the act of caregiving, with the overall goal of reducing the stress and really helping the family to be able to function healthily, and with the ultimate goal of really trying to avoid out-of-home placement and placement into the child welfare system when that's possible. And so the settlement definition requires the state to cover respite care as a Medicaid benefit. And as you'll see in the blue highlighted box here, outlines a little bit about the parameters about that coverage, which we'll talk about in a little bit here. Next slide, please. So just a little bit of an overview of what respite care can look like, and it can look very different, but it can be everything from just sort of helping with the basic daily living skills that families are doing with a child. It could be doing outings, going to activities in the community, could be helping with some meal prep or some things around that, as well as some of the other caregiving opportunities. So respite care can look a lot of different ways depending on what the family needs. Again, the core goal of respite care is to give families a break from being solely responsible for some of those caregiving duties and freeing up some of that space. And so this list here is certainly a menu, and it's not exhaustive. We are currently looking across the country at what other states do cover under the respite care benefit. It's not a completely wide open, but it is pretty flexible. And so we want to take a pretty broad brush in terms of what can be encompassed under this, and then see what the federal government will allow us to do in the end of the day. But we want to start with as expansive of a service as we possibly can. Next slide, please. So just some of the baselines just to understand a little bit more. Respite care, as outlined by the settlement, can be both something that a family schedules ahead of time and plans for. Maybe there's a vacation happening with other family members or another family event that you want to plan around. Or it can be utilized as an intervention when something comes up unexpectedly. And that's often referred to as unplanned respite or crisis or emergency respite. And our intention is to offer both forms of the service. And respite care can be something that happens during a single day for a few hours, or it can be something that involves some stays overnight and often up to a few weeks in other states that we've looked at. But sort of that length of stay is another thing that we are going to be looking at, about how long can respite care be provided and what does that look like. And respite care can be provided in a lot of cases. We really want to bring respite care into the home where that's possible and appropriate, but that could also be other community-based activities, as I mentioned earlier, going to camps, YMCAs, outings, or it could be in a more facility-based, more traditional provider-based setting as well. And so it really does run the gamut in terms of where and how respite care can be delivered. And another piece that the settlement outlines for us is it's specific that we need to offer respite care that's provided both by licensed or certified professionals and agencies, as well as by what are often called natural supports. So other important people in a child's life that have some kind of training and vetting to make sure that they are safe and qualified and up to the task, but recognizing that having someone that the child is and the youth is connected with and the family knows well may be a way of both addressing provider shortages, as well as just might be a better fit for the situation. And so wanting to make sure that both of these options are available to families in Nevada. Next slide, please. So, as I said, we are just in the very beginning stages of designing what this will look like. And part of that effort is hearing from you all about your experiences. This will require a rather involved federal approval process. We're actually working with some of our other contracted vendors to understand what the particular path is, but unfortunately, we cannot cover this as a traditional state plan Medicaid benefit, which is the easiest. And I say easiest with a big caveat, nothing is easy in the world of Medicaid, but it's the most straightforward. And unfortunately, respite care is a unique enough service that there are different federal parameters that we'll have to navigate, which just means it will take us more time to really get this stood up and may have some additional administrative steps in the process as we get there based on which federal path we pick. And that's something we can talk about more as we get a little bit more developed here. But our goal is to have this available as a billable Medicaid service by January 2027, and something that could be accessed as youth are linked up with the specialty managed care plan that we've been talking about. I should acknowledge that respite care is happening in Nevada today. You all heard from Magellan a few sessions ago, and they talked about the work they're doing. Respite care is one of the services that they're offering. And we also have this in our disability world as well. It's just going to be a unique service as a covered benefit for youth with behavioral health challenges. And so that's what we're here today to talk about. How do we do that right and do it in a way that's going to really meet the needs of families in Nevada? Next slide, please. So as I said, probably 18 different ways, we're here just to get your initial feedback. This is the first of many, many discussions. And so there are no ideas too broad, too big, or frankly, too in the weeds at this notion. We are building this ship in real time. And so this is our first opportunity to really kind of get some feedback. So we've got a series of questions that we're hoping to get some feedback from this group on as we embark on this development work. So these are the 5 questions, which I'll read out. We don't need to take them one at a time. Really want to make this sort of an open discussion. So pick the question or questions that resonate most with your experience and the perspective that you bring to this work. So what would a good respite care service look like? What do you think might be a concern or worry for youth and families about accessing or using it? What do you think might be a concern or worry for service providers or other kind of administrative agencies that are involved in this? And then what kind of experience, background, or training should respite care providers receive? And I think of a particular importance is how does this look different when we've got licensed or certified professionals versus families or other natural supports that are not connected and don't have those same kind of oversight and trainings that you get through the professional background, but still play such a crucial role in helping their families and the people that they care about. And then anything else, as again, this is the first conversation that we're really having in earnest about this. And so any ideas that you all have at this juncture, we welcome them. This is a blank canvas. And so really excited to hear what this group has to offer for us as we're thinking through this new and hopefully really impactful service coming to the state. So with that, I will open it up to the group and we can have some dialogue here.
Yeah, Sherilyn, good to see your hand up.
You know me, I'm always gonna have a question. So
Welcome.
that's just who I am. So Sherilyn Rowood for the record. So quick question. Love Respite. Think it's a great, just a great program. It really does help families. I am concerned about how you're looking out into the rural areas to make sure that we can build respite out there. They have been lacking respite for a long, long time. We know part of that is due to that workforce or families being able to stay home and work, do that level of care for their family members. So I'm really hoping as you're building this, and I think I'm on number 5, we really need to consider how do we put respite out into our rural and frontier regions. And I'm talking mineral, further out where there really isn't a lot of stuff. So I think we really need to think about that as you're designing it. So that's where I'm just going to keep my piece.
Thank you for keeping that front of mind. I think especially with Nevada and just how the rural areas of our state are set up, it is something that is a challenge that we just have to wrestle with every service, and a unique service like this particularly so. One area that we've looked at in other services is how do we frankly compensate for that in our reimbursement structures. That's one tool we have, but would welcome other ideas for folks on the ground about creative solutions about how we can get that access out there, because I think frankly, that's one of the questions that keeps us up at night, that we don't have any good solutions about how to create access in places that don't have it today. So I think part of that is leveraging this natural supports idea, but how do we do that in a way that is making sure that we're meeting the needs and not putting youth or the people providing this respite care on a, not a volunteer, but on a non-professional basis, keep everyone safe and making sure that the outcomes are good. So a lot to wrestle with there, and I appreciate you keeping that front of mind for us.
Wonderful. I think Britt, I saw your hand up next, and then we have a couple questions in the chat as well.
Yes, I just want to echo what Sherilyn said. I love the idea that you have the option of self-directed respite for families, but a lot of families, they don't have those natural supports that we've found in the past. When self-directed respite was available, it was a large barrier for families that don't have those natural supports. So yeah, building that workforce is going to be vital for families, especially in the rural areas. And then I just wanted to say another barrier that families might have with respite is transportation to get their youth to respite if it's not in the home. So that would probably be another thing to look into and see if that's going to be covered with this service to support families with that.
Thank you. That's really helpful feedback. I do believe we need to look at the intersection here, but transportation is another benefit that we must be covering as part of the settlement agreement. And so looking at the intersection of those is really key. So thank you for lifting that up.
Absolutely. Thank you, Britt. Matt, I'm happy to read the questions in the chat here as well. So Dr. Courtney flagged a concern about potential barrier for providers would be hoops required to become a unique provider type. Any thoughts on that piece? I know we've been wrestling with that internally for all these services as well.
No, that's great feedback and something we need to keep in mind. As I said, we are 50 steps away from is it under an existing provider type or a new one, but would love to hear more as we go on here about some of the barriers there and how we might streamline that, because I think that's a very valid issue to be raising. But just thank you for flagging that.
Mm-hmm. Yeah, thank you, Dr. Courtney. Sharita's asking a couple good questions here. First is, do we currently have enough trained and qualified respite care providers to meet the projected demand across Nevada? And then I'll let you answer that first, Matt, and then we can go to the next one.
Yeah, I would say anecdotally, it is almost 100% certain we do not today. That is part of the work that Magellan is doing, is trying to help us build out a provider network, and that will be part of the ongoing work here. But I think the workforce challenges underlie all of the work that we're doing here. So I can't sit here and say, oh, sure, we've got enough. I can guarantee we don't. And so we've got to come up with solutions on that front. Absolutely.
Yeah. And that's part of what we're doing with our partnership on that Connect Nevada program as well, is as they're able to support with infrastructure funding and seed funding for our providers, we can have conversations with them about how can we ramp that up to become a Medicaid enrolled provider, recognizing that that is a really crucial, one of many crucial funding sources for providers. And so we're hopeful that, our ability to start paying for this, albeit in January 2027, will help, but recognize that there's a lot of work to be done on the workforce front across the board. So thank you for raising that, Sharita. Second question there is, how many respite care hours will be allocated per child or per family? And how will this be determined? For example, based on medical necessity, diagnosis, caregiver stress, or other factors? Matt?
These exactly are the questions that we are weighing right now. None of that has been determined. So we are doing an analysis of every other state, especially similarly situated states, just to understand what has been allowed by the feds in the past and what sort of the general parameters are. But we don't have that nailed down by any means, and so would welcome any feedback that folks have or any suggestions and recommendations on both the kind of the amount of respite as well as sort of what's that eligibility criteria. Those are definitely two of the key factors that we want to be sorting out, but we're not there. And once we have some draft ideas on that front, we'll definitely bring that back to this group for reactions.
Wonderful. A lot of good comments in the chat here. I want to make sure we get to some of the hands raised. So Dave, do you want to share next, and then we can go back to the chat?
Sure. Good afternoon, everyone. Dave Doyle with Eagle Quest. Something that I would encourage you guys to consider, and you're probably already doing this, but we're one of the providers doing respite currently for Magellan. And to be honest, guys, we're students. We're learning every day. We're learning from every case. And I suggest we take advantage of all those students who, i.e. providers currently doing respite, and really develop a think tank with them as to what they're seeing, what type of hours, authorization, per child. And I think we can learn a lot rather than reinventing the wheel with some of the stuff that's been done the last year or two. And we'd be happy to kind of help organize that group. And you've probably already thought of that, but just wanted to throw that out there. Thank you.
I promise I didn't plant that question, but thank you. And yes, we will be talking very soon, because that was a sincere hope of ours. And again, since we're building this infrastructure in Nevada, it doesn't make any sense when we transition this from the grant funding through Magellan to a Medicaid benefit to then make all the providers that have set up all this infrastructure completely reinvent the wheel. Recognizing, of course, Medicaid has some of the most arcane rules of any programs that we work with in this world. So I'm sure they'll throw a few wrenches at our way, but would love to collaborate, and we'll follow up after this about getting that group organized. That would be immensely helpful for us.
Yeah, thank you as always, Dave, for your input there. Britt, seeing your hand, let me just get to one more question in the chat and then I'll come back to you. So thank you so much. Jess flagged about looking into other states, as Matt mentioned. That is absolutely something our team has been doing. We've had some good conversations with other state Medicaid teams as well. And we're looking to set up some conversations with some respite providers in other states, including Ohio, to learn more from their approach. So appreciate that nod. Definitely a good way for us, to Dave's point, not to reinvent the wheel. Leah echoing concern for safety of natural supports and really wanting to ensure there's some appropriate guidance there. Absolutely appreciate that input. Shayla raised an interesting point about what the age frame would be for how long this benefit is accessible. She flags there's no respite for adults that's billable without hospice. So what's the transition between a benefit within this program to the adult care as well? Matt, any thoughts on that?
No, I think that is one of the major factors, is what is that upper age band and how does that look? Some of that might be constrained by federal parameters, and obviously this effort is focused on youth, but I think we all know that youth grow up to be adults and don't stop having whatever issue they were doing by the matter of turning 18. So no clear answers there, but that's definitely something that's on our radar, and we'll want to have more discussion about. Unfortunately, I think that might be one of the ones that's more challenging to mitigate, just simply because these systems pour a lot more support into youth, and we have a lot of cliffs in our systems once you turn 18 and become an adult, or when you're 21 in some circumstances. But more to come on that. But I certainly agree with the sentiment, and we'll see what we can do to mitigate that. But I want to recognize our hands may be a little bit tied there too.
Yeah, I appreciate that, Matt. And I know that's a concern that Karen had raised on a broader point about transition into early adulthood. So I think that's a great topic for us to tackle with this working group in the months ahead, to really think through how can we design the handoffs as best possible given the federal constraints, but recognizing we don't want to build the system that doesn't have a next step for kids there. So thank you for that. Britt, I'm going to go to you.
All right, so this has probably been covered, but I know one concern that a lot of families have when their children has behavioral health needs is the lack of childcare or respite, because their child gets kicked out of every childcare that they go to, or every respite care they go to. I don't know what it is that Medicaid can do about that to support the providers in better training so that the respite isn't turned away from families when there are behaviors, and children and youth are not getting kicked out of places because they do have behaviors. It's definitely a service that families really need, but also the training for to determine if the youth is possibly escalated to the point where they need to get a mental health assessment, and do they need to be on a mental health hold? Some kind of training of that nature would probably be very beneficial when it comes to like a crisis point. But I would say like some kind of procedures and training when it comes to that with behaviors, when it comes to the respite care, would be really helpful for families. And like I said, a lot of these families, they don't have a daycare, they don't have childcare, they don't have natural supports to go to watch their child, because no one wants to watch them because they have behaviors. And so this respite is like their lifeline to get some kind of time to themselves for self-care. And so I think it's just really important, not to take over the whole time here, I think it's really important to look at how the training is going to affect the youth and the families in the long run when there are behaviors.
No, I really appreciate that. I think the training piece of this is something both for the formal providers and the natural supports that's going to be really critical. So thank you. We've got that noted, and I think that'll be really helpful as we're kind of fleshing out kind of what does it take to become a respite provider, and what do you need to know, and how does that look? So that will be useful there. And definitely hear you about the kids who could most benefit from this are probably the ones that we're going to have the hardest time connecting with the respite provider. I don't know that we've got great solutions to that right now, but that's the entire point of this effort, is we need to build up. We are under a federal court order to make that happen. So like we're going to be able to leverage our specialty managed care plan, the growing provider network to make sure that we're not turning youth away from every single access point that there is. There's got to be someone that can serve every youth in Nevada, and it's going to take us some time to get there, but I appreciate you raising that.
Thank you.
Yeah, no, thank you, Britt. That's a really thoughtful question, and Matt, spot on. And I think Matt Lehman in the chat maybe had one idea to that point, thinking about RBTs being a potential provider here that may be equipped to support youth with some more complex behaviors or needs. So appreciate that idea, Matt. We'll note that down. Amy, seeing your comment here about small and individual providers may need some support as they enroll with Medicaid, knowing this is not an easy thing, particularly for folks that don't have as much experience or any experience enrolling within a state program in that way. So I appreciate that nod. I think that's going to be true for all of these services and something that we need to really think through as a state. What's our technical assistance that we can provide to make these easier and even just make the way we talk about it easier because we know it's not always a very straightforward process. So Matt, anything you want to add to on that piece?
No, I think that's here.
Oh,
That's
sorry,
that's front of
wrong
mind. Oh, sorry, Rich Matt.
Matt, do you have something you wanted to add there?
I was just gonna say that one of my thoughts that struck me with the individuals needing help with that kind of stuff, if that got potential, I don't know if it's even possible, but if some of that stuff got potentially integrated with just the application for RBT licensure, so that it sort of automatically paneled you into, like if that was just an extra sheet that you signed, you were automatically paneled into that would facilitate those people who finish the licensing process and then don't know where to go from there to sign up for things because they're not necessarily connected to a company just yet. That might be a way to smooth that out, if that makes sense. I know there are other states where the moment you get your license, they do in fact automatically panel you with the state's Medicaid. Like it's not a separate application. It's just you've got your state license. You are now enrolled in their fee for service or whatever Medicaid to just remove one of those extra reduplicative steps.
That's a great idea, Matt. And definitely those types of structural ways to make the process easier for our providers is something that's top of mind. I will note for the health authority as well, not to steal thunder from the stakeholder workshop in a couple of weeks, but that is something that we're looking at across how can we try to align more generally across all of these state run health programs? How can we make it easier for providers to participate and be part of those, recognizing those steps like enrollment can be made a lot more simple. So appreciate that. We'll note it down and share it with our provider enrollment team as well. So thank you for that. Seeing a couple hands up here, and then we'll go back to the chat. So Dave, I think you were next.
Hey, thank you, Ann. So just as we're talking about like workforce for respite, whether it be the RBT process, I'd also like you guys to consider the existing specialized foster care workforce. We talked about kids who are very hard to work with, kids that few can't. Most, we've got hundreds of trained staff in crisis stabilization, intensive in-home services, and you might have a good workforce in addition, not taking away from another one, but we need as much as we can get because we're not going to have an ample workforce to start off with. So that might be another group that you'd want to work with, that provider group as well, I would just add.
Yeah, that's a great idea. Thank you, Dave. Matt and Sarah Dearborn work very closely together on these things. So I think that's a great idea to try to think about some synergies of those providers as we go through this. So great idea. All right. I saw a hand up earlier, but not now. So we're gonna go back to the chat and then feel free to chime in for folks that are interested. Jana, really excited for you and Matt to connect on the self-directed respite learnings through that system of care grant. Julia, thank you for that feedback there. Would love to have a deeper conversation. You actually beat me to an email that I have on my list to send to you all and our county partners about thinking through some of the funding streams there. I think most generally there's a lot for us to figure out, but we all know that Medicaid funding can never be the sole financing source for services and for our providers. It needs to be a mix for it to be sustainable, especially given the constraints of all of these resources. So I'm looking forward to working with you to figure out the right path forward, particularly with our youth that are involved with child welfare, and glad to see your excitement about more respite. We are feeling that as well, and appreciate all this input as we make that. Dr. Durrett, seeing your question, beyond respite, how do you envision the system addressing youth mental health crisis in the situation of crisis respite? In other words, what will be the treatment, assessment, evaluation requirements? What's the community bandwidth to help youth in crisis with their diagnostic and treatment needs, which is separate and distinct from respite provision? That's a great question. Matt, do you want to give some initial thoughts there?
Sure. I think crisis is another area that the DOJ settlement sends a lot of energy around, and I think we'll probably be having a bigger conversation about all things crisis, and so I might defer some of that conversation there. That's really looking at the 988 infrastructure, our mobile crisis teams, and that's even looking beyond the Medicaid population. So maybe you want to just note that and thank you for that, and then maybe table that for our deeper conversation on crisis when we're at that juncture.
Absolutely. And Dr. Durrett, if there's recommendations you have of things that we should think about as part of the respite piece now to think about that connection between emergency respite and crisis systems, we would love to hear it. So thank you for flagging that. Dee, seeing your piece, OT providers are trained in mental health as well. Yes, I love all these creative ideas of folks that may be able to support or provide more network for our respite care population. That's wonderful. Any other reflections, questions, recommendations as we begin this process?
And this is Julia, just one question. I'm wondering about in the same thing that you did with PRTFs, where there's an extra rate for more challenging behaviors, if we couldn't consider something like that for respite too. Is, I think as was alluded to before, where we do have children who've sort of made the rounds of all the providers and they just take more staff time because of their needs. And so I don't know if that's a tiered rate could be considered here. Thank you.
Yeah, great flag. Thank you, Julia. Matt has been working on that tiered rate for our PRTFs. Do you want to share a little more thinking or reflections there, Matt?
Yeah, absolutely. I think that's a strategy that we're looking to employ in many different spaces, and so that's definitely on the table. Like I said, we've gotten as far as written the outline of all of the categories and questions we want to ask, and you have added to that list today, this group has, and I want to thank you for that. So that's definitely on there, and as we get to the reimbursement, I have to imagine that it's been pretty consistent. We've looked at differential reimbursements, and if that's something we can make happen, I'm guessing that's the route we'll go, because we just know it's a different level of effort out in the rurals than it is in the urban areas.
Yeah, reflecting cost of service provision through those differentiated rates is something that is of interest to us across a lot of different areas, even beyond behavioral health. So thank you for flagging that. It's a really great idea to add that to the list here.
Okay, and if I could just clarify, just because I was completely with Matt until that last piece about urban versus rural. And so we're really talking about children in the urban setting who have more challenging behaviors. And so therefore,
and the complexities as well. Yeah. So that's something we've also looked at as well. So everything is on the table on the reimbursement front. So I think the goal, of course, is to pay enough to actually have people able to sustain themselves doing this service, and that we can actually get kids access. So whatever it works in spirit of those goals, we're interested in looking at that. So, and thanks for the clarification.
Yeah, absolutely. I imagine, Sherilyn, your ears perked up at the rural piece too. So I think that's something we've employed for different services, right? Differentiated service depending where it's delivered and what staffing or resources are required to deliver it in the right way to the youth that we're serving. So glad that we can have both of those on the table there. Great. Any other questions or reflections here? Right. Well, this has been a wonderful discussion. Matt, any closing words here to wrap up our respite piece?
Well, first of all, just thank you. This has already gotten my brain going in 80 different directions, and I'm sure a lot of folks on our team as well. So this has been exactly what we were hoping for on today's discussion. Just in terms of next steps, we are going to be huddling internally. I've got at least 2 meetings to schedule with some folks coming out of this call to get some more feedback from folks that have been doing this on the ground. What we'll be doing from here is kind of building out the scaffolding of the policy framework, and then want to bring that back to this group for more discussion. So we'll have a bit more meat on the bones about all the good points that you all have raised around eligibility, around reimbursement, etc. And so a little bit more substance to react to. Again, before we finalize everything, we want to make sure that we're gathering as much input and designing this as best we can from the get-go. And thankfully, while that January 2027 timeline is coming up quickly, it does give us time to do this thoughtfully. So I would expect in the coming months, we'll be back in front of this group with a little bit, like I said, more meat on the bones to react to. But this has just been such an amazingly wonderful discussion tonight, and we've learned a lot from you all. So thank you.
Yeah, thank you all, and thank you, Matt, for really setting up this discussion beautifully. So I appreciate it. With that, we will move to wrap up today. Want to thank you all for joining and invite you, of course, to our next meeting on August 14th. So again, second Thursday of the month there. And with that, we will move to our public comment period. So as a reminder, please provide your name before you comment, so that way we can record that for our minutes. As a reminder, no action can be taken on a matter unless it's on the agenda already. And we encourage comments to be limited to 3 minutes per person. So with that, I see Anya, your hand up.
Hi, this is Anya Earl from SAFI. I was just going through some of the public workshop presentations that I'd seen in the past. And I know that in the March workshop, it talked about some really specific rates for the outpatient behavioral health. And it looked like it was going to CMS. And then in May, those rates changed pretty significantly to a flat 10%. So I'm wondering, did they get submitted to CMS as the original rates? And have we heard back from them? And where's the 90-day timeframe where we're at with that, if you have any of that detail?
Absolutely. No, thank you for the question, Anya. So what we submit to CMS is actually more about our authority to pay for the services, and then our fee schedule is where the rates are reflected. And so, as you noted, what we're moving forward with as of right now, given the uncertainty with a lot of the budget landscape right now, is somewhat of a stepwise increase in those rates. And so the 10% rates that were approved by the Interim Finance Committee as part of the legislature last year are the rates that we're moving forward with right now. As soon as we do receive the CMS approval for the authority to change our reimbursement at all, we will turn that on in our system and reflect that as soon as possible. And of course, we'll keep all of our providers posted through our web announcements in this forum on when that happens. We're then taking a close look at our budget on the next stepwise increase from there. Our goal is to get as close as we can to what was shared as our kind of ideal rates back in March, and recognize that the world we're living in right now may look a little bit different then. And so we commit to being really transparent with you all on what those decisions look like throughout the process. So does that help answer your question?
Yeah, it does. I am curious, just because CMS, when we went through our own SPA experience for specialized foster care, there were really tight timeframes. And so I'm wondering, do those timeframes, are those being adjusted because of the federal changes that are happening, or do we have a hard deadline that we're looking at and we can expect? Just because we want to be able to anticipate when those rates might change and when we can talk to our own staff about what that looks like.
Yeah, of course. I appreciate that. CMS timeframes are the same. Those are part of regulation, so those will be consistent. As you mentioned, there's an initial 90-day window. However, there is an opportunity for CMS to extend that as they ask questions and we go back and forth on things. So that's the back and forth phase that we're in right now. We do anticipate that process will conclude, we're hoping, within the next month. But again, there is a little bit more flexibility. There is no hard deadline when we are in that very regular back and forth conversation. So I wish I had a more concrete date to tell you, but I do hope to have more information for you very soon. And know that we're working on our end. The things we can control about getting these all ready to go in our system, we've done that work now, so that way we can make that turnaround as quick as possible when we do get that final green light.
That's great to know, just that you're in that back and forth phase. That means we're getting closer. So that's great. Thank you.
Exactly. Yeah, of course. Any final items for public comment? All right. Well, with that, we will close. Give you all 3 minutes of sunshine on your Thursday afternoon. But thank you again for your time. As always, it's been an excellent discussion, and I look forward to seeing you all in August. Take care.